the speed with which it goes. And it's quite helpful because earlier we used to have about 2 hours, 1.5 to 2 hours, and cross only 250 to 300 centimeters. With this, now we are able to cross the entire small bowel within a short time. It varies depending upon right from 20 minutes to 30, 40 minutes, and sometimes an hour also. There are various factors for it. So, with this brief introduction, may I invite today's chairpersons, Dr. Prakash Jain, consulting surgeon. Please join. He's a senior surgeon at Kingsway Hospital. We have Dr. Atul Gawande, Dr. Shashank Vanjari, and Dr. Gaurav Padi. All these four persons are the chairpersons. We have Dr. Vikas Singla, who is a consultant gastroenterologist at Max Hospital, Delhi. We have Arun Iyer, who is a consultant gastroenterologist practicing at Raipur. And we have Hitesh Dudhe, who is a consultant gastroenterologist at Yavatmal. But probably I think he is traveling, so he may not be able to join. So, with this brief introduction, I hand over the mic to our chairpersons. The theme is small bowel, so we have some interesting cases pertaining to small bowel. Thank you.
Cases. Small bowel is always um, a long thing. And without further ado, we'll ask Dr. Bhushan Baware. Coin stuck in a jejunum in a 7-year-old boy. What to do?
Yeah, good evening, everyone. Good evening, our chairperson. Uh, yeah, so this is a very nice case of a child who had just came to a hospital. Rather than a 7-year, he is just a 5-year-old boy who had accidental insertion of an coin, approximately of 1 rupee, on 1st of April, it was 23, accidentally while playing with the coin. There was no associated any alarming symptoms which are associated after ingestion of this coin. Patient has done some. Patient didn't seek any medical advice till 7 days. He lives in a very remote place in Yavatmal, and by the day, patient thought that we should do an X-ray. Patient is completely asymptomatic, doing very well to do at his home place. Doesn't have any symptom. Somehow he thought that we should do X-ray. So what he found that at day 7 there was X-ray. The stone, which the coin which was slowly moving from stomach to small intestine, and even at 15 days the coin is very passing. And somehow the doctor at residence said that the coin is not moving further, and patient was referred to our hospital for further evaluation. So he came to Midas with mild abdominal discomfort. He's having some discomfort. I think more anxious rather than any upper abdomen was soft, vitally was stable, and we also did an X-ray abdomen erect, and we thought initially the radiologist report it is in the colon. Okay, no issue. We can stop. But somehow we thought it was a very not a 100% it is in colon or some in the jejunum loop it is overlying. So for confirmation, we really did a, CT, and CT contains a lot of artifacts in between because the child is just 5-year-old. Our radiologist report it was a colon which is seen on the right side. We can see a brightness which is more showing from the near about proximal jejunum, mid jejunum. So we sure that it was not in the colon. It is into the somewhat into the proximal jejunum to mid jejunum area. So with this summary, a 5-year-old kid with an accidental insertion, coin is not moving further in the small bowel, rather impacted. It is like around 23 days, which the patient is having. Patient is partly asymptomatic, and parents are quite anxious, like what we should do further for this patient. So I really asked to our panelists and our all these people that what should be our approach in this patient? Can we really observe it or go for endoscopy in the form of he's a 5-year-old kid, or we can go for surgery? Yes. Anyone like how we should really approach? He's a really a guy who's completely a 5-year-old. I give a further statistic is a 14 kg in height is around 3 feet and patient is asymptomatic. Should still we observe it? Like, no, absolutely, sir. Absolutely, Gaurav. There is no signs at all of any obstruction, bleeding. Yeah. I also want to show it. Like, there are looking some air fluid levels in this X-ray. Yes, but patient was asymptomatic. I think.
I think lot much time has already been given for
Yeah.
observation, and patient is starting to develop at least some symptoms. Initially, he was playful. Now, when they are referred to Midas, he was having some other symptom that should be considered.
Yeah.
And waiting too long might complicate.
Yeah.
So I think one can proceed doing an invasive thing like if we have enteroscopy, so
Yeah.
one can go forward with it.
Yes, sir. But 5-year-old kid enteroscopy, at least double balloon enteroscopy is not feasible. So surgery, like we really in this scenario. Yeah. Yes. Absolutely. No, the diameter is 1 rupee, sir. A 1 rupee coin is very unlikely. But yes, we are in endoscopy center. We really tried first. Really, we give an option to the patient that we can try one attempt of an endoscopy, and if not feasible by endoscopy, we'll go for surgery if required. So it's the 7, like we can perform at least a push endoscopy rather than doing any form of spiral. We can do some sort of push endoscopy. So this was the procedure detail. What I thought I should do a push endoscopy. I did by 190 scope therapeutic Olympus. We didn't do under general anesthesia propofol sedation. We do in both left lateral and supine position, and we use a fluoroscopy just to guide like while doing. So this was a interesting. Yeah. So as we moving, I was very careful that not to inflate much of CO2. I mostly tried by water just to advance my scope deep into the jejunum. So I was very slowly going very carefully under fluoroscopy just to measure where we are heading into. Okay. Yes. Sir. Yeah. Yes. Sir.
People should appreciate that the way depth which is covered by the scope has to be
Yeah. Yes. So as I said, that I hardly with a minimal CO2 inflation, as we all know that I was really advancing the scope under fluoroscopic guidance to make sure that we are really advancing. We are making some progress, but because at the end it's a push endoscope. It's not like a balloon scope. We have to pleat it. We have to really push it with a careful, because considering a risk of all the GI bleeding, perforation was always on the card. After greater explanation to the relatives that yeah, this is one of the attempt of doing an endoscopy. You can see the scope is really looping and very advancing into the small intestine. We are going quite deep. As you see, yes, finally I can able to see my scope is getting near to the coins, and then I located the coin, and we can see there is some stricture is also there into the proximal jejunum. The patient was nearly symptomatic for that. I used a rat tooth forceps. It was finding a little bit difficulty, so I make it in a proper orientation to grab it by a rat tooth forceps. And finally, with minimal maneuvering, I able to grab it by rat tooth forceps and slowly pull it from that jejunum area. Yeah. So as you can see, fluoroscopically, we can very carefully removing the coin, and we contemplate the procedure in around 15 to 20 minutes. I contemplate this procedure. So post procedure doing fantastic. Patient has no complication for that. But we found in that hurry of removing the scope, there was stricture. What I mentioned here, as you can able to see. I didn't take any biopsies because the primary intention at that point is to just remove that coin and just come out. But I can see there is something narrowing with the scope. That's why the coin is not moved further. Then we do a barium mill follow through just to make sure it is a proximal jejunum. And with a good experience, there is no stricture in this patient. And also the patient was never symptomatic prior to that coin for that scenario. And so we give them an option, okay, if the patient develops some site of small bowel obstruction in the future, we start evaluating this form of stricture. So this is a very straightforward, simple case where we avoided the surgery and where we really contemplated we can able to do by doing a push endoscopy. So as you all know that in take-home message that majority of foreign body which enter into small intestine are passed spontaneously. Enteroscopy is the standard practice of removal of foreign body, and this by doing this gastroduodenoscope, which is a therapeutic scope, may be useful for some intestinal foreign body removal. Thank you. Thank you.
I think I must compliment Bhushan for doing a marvelous job, because in fact this patient was seen by me for the first time, and I thought that it is possibly not reachable with the help of endoscope. Presume because the X-ray had shown the coin in the pelvis lower down. And in fact, how much must be the centimeters which you have traversed beyond?
If I call from DJ, we can come around 30-40 centimeter. I went inside. Yeah, at least one loop.
Maybe
Yeah.
more. Maybe more.
Maybe more
actually.
in it also. Like I can see, it's very difficult. At least 40-50 centimeter. I was going inside, tracking the.
So in fact, that was the first day we had our spiral. So we wanted that, can we do a spiral? But below age of 7 years and 8 years, spiral was a big no-no. So enteroscope again, the same, the diameter and other things are so big. So I personally thought that a mini incision exploring would be an ideal. But two things. One was obstruction, which was seen on the X-ray. So otherwise, the coin would not have got stuck. Once it has passed the G junction and pylorus, there has to be something.
Yeah.
Because basically, the patient was in hurry of going to call him and find out whether there is a stricture in the small bowel. Sometimes you have vapes, diaphragm, and things like that. He's too small to have NSAID-induced ulcers. But I feel that there is a narrowing looking at the endoscopic picture and which needs evaluation.
We'll see, sir. He's completely doing well. Today only I called. Doing well.
Yeah, just a comment. I think oftentimes the question comes, which endoscope, what age group? And this was a 5-year-old child. So of course, this is actually lowest end for double balloon enteroscopy. So we have all the three options for us to choose from: spiral, which we'll talk about a little later today. Double balloon enteroscopy, you can do up to 6 or 7 years of age, and sort of depends on the weight. This one was a 5-year-old. So again, you would be apprehensive because at the end of the day, the balloon is not designed for children. Although it can be done in 6 and 7-year-olds, it's meant for adults largely. So if you inflate the balloon, pull it, and then traction and trauma to the bowel. And I think we were hoping for an endoscopic option, but then I felt a little helpless when I received the call and said, it's 5-year-old, it's very hard, and deep in small bowel. Spiral I can't do, double balloon I am a little wary, I'll cause a perforation or something. So Bhushan decided to go ahead with the endoscope, and all kudos to him. He managed to do it successfully and retrieve it. Even we were surprised that it actually worked out. So thank you.
Very well managed case, Dr. Bhushan. I had one query, that is there, apart from the age of the child, which was 5 years, is there any role of a lavage in a small bowel clearing? And I don't think, because when you're doing this scopy in the stomach, in the small bowel, there was no residual fluid. It was not showing any obvious obstruction, or maybe the levels, air fluid levels. So do you find that there is a role of giving a good lavage or clearing the small bowel from any polyethylene glycol or anything like that?
You want to think
Because
we
I-
want to
because,
do some sort of lavage, means you want to give some sort of peg-leg type of preparation and just make sure that
Exactly, because in our previous days we used to link any foreign body which crosses the cricopharyngeus usually passes out from the intestine.
the dictum is that every small intestine, every foreign body, unless the length is more than 5 centimeter, or breadth is less than more than 2.5, it had to pass. This foreign body was not passing. As sir said, there would be something like we are able to see some stricture. If it had been given some stricture, and if it is very practical, I can see a few air fluid level on the stomach, and I am advising to at a 5-year kid get a peg leg 1 liter. I don't know how results would be.
It might have precipitated obstruction.
Maybe, sir. It may be a precipitated obstruction. Maybe, sir. I wonder.
And the other thing, as I said, passing through terminal ileum could be a very difficult job
These
for
are the few
any
sites where the
foreign body.
coin get obstructed in the
Yeah.
small intestine.
Actually, it's quite rare. It's quite rare for a foreign body to get obstructed in jejunum. So, as sir rightly said, one must always suspect that there must be some underlying pathology that is obstructing it.
Really well-
Otherwise, if the coin is passing through the cricopharynx, then it should normally come out.
Absolutely. Absolutely. Absolutely.
I think,
we're really, we're really watchful for that patient in
Yes,
the
yes.
future, like whether she has developed some symptoms.
True. Yeah, yeah. Obstruction there.
Hmm.
But like in subacute cases, we do try to give contrast or anything like that. Maybe that can help.
From that time, it's started getting sometimes whenever you have doubt of obstruction, better to get one X-ray first rather than giving them peg upfront.
Just out of interest.
Yes, so battery is an most of the one emergency thing. We are talking about what you call lithium batteries and cylindrical. We are talking any batteries. The exactly the button battery is what you're talking. Yes, sir. We had to do. Well, it is one of the emergency. We don't wait like a standard protocol. Like once he's in the stomach, we let him pass into the duodenum. No, it's one of the very emergency. They causes a very bad necrosis and ulceration and even perforation. If a patient has history of any coin ingestion, we had to attempt to removal at any cost by endoscope. If it is feasible by endoscope. If it is feasible by surgery. Yes, sir.
Any valuable comments by Dr. Arun Iyer?
Sir, I want to ask one thing. As
Your
Mukhiva sir
mic
told
is
that
off, I
there,
think so, sir.
there appears to be a stricture.
Yeah.
There appears to be a stricture, and can it be allergic gastroenteritis or very early onset IBD? Because the coin has not passed since 7 days. So there must be
It's
some
7 days,
reason why it
23
has
days.
not passed.
23 days.
23 days, Dr. Iyer.
23
The
days. So,
coin was stuck in the intestine for 23 days.
so sir, generally it should pass in say 5 days maximum, but uh, should it be evaluated or not is my question.
In fact,
Thanks.
we told what has happened is next day we ordered the barium. The barium follow through was normal. So without the report
Further,
being recognized, he went up also because the coin was removed. But I feel that looking at the
Endoscopy image.
intestinal pictures, I feel that there is definitely diaphragm like. If this would have been an adult, the first diagnosis would have been NSAID induced enteropathy.
Agree.
Thank you,
As
sir.
you rightly said, eosinophilic enteritis is also one
Or
of the
Crohn's.
possibilities. To say it as isolated single stricture in a 5 years old boy as a Crohn's is less likely with entire small intestine, absolutely normal.
Thank you, sir.
Thank you, Dr. Bhushan. That was an interesting
Thank you.
discussion. Coming to the next case by Dr. Atif, a great punch, diarrhea and small bowel thickening.
So, good evening, everyone. I'll be presenting a short case of painful small bowel diarrhea, and I would require your inputs in a differential diagnosis. So, an 18-year-old female presented to us with abdominal pain since 1 month. It was acute in onset, continuous in nature, mild to moderate in intensity, located at the paraumbilical region, non-radiating and not related to food. She also complained of vomiting since 1 month. It was bilious, large quantity, occurring after 2 hours of food, and loose stool since 1 month, large quantity, watery, occurring 5 to 6 times per day, suggestive of small bowel type of diarrhea. The biochemistry showed microcytic hypochromic anemia with hemoglobin of 10.1. You can see inflammatory markers were raised, the ESR and the CRP were raised. Along with that, the patient had transaminases with AST and ALT of more than 150. So microcytic hypochromic anemia raised inflammatory markers, transaminases. The ANA was positive. However, the double-stranded DNA was negative. And on urine, you can see proteinuria. The CT scan, you can see small bowel loops, almost all the small bowel loops are thickened. Besides that, the colon, the large bowel, the sigmoid colon is also dilated. There is mild hepatomegaly. What is not seen in the image is presence of splenomegaly as well as mild ascites. So we went ahead with an endoscopy, and endoscopy was fairly normal. We went up to D4 jejunum junction, and the entire upper GI scopy was normal. We had taken multiple biopsies from D2. However, the histopathology was not specific. It just showed mild lymphoplasmacytic infiltration. We also did a colonoscopy, which was fairly normal. So what would be the differentials of 18-year-old female who presented with abdominal pain along with diarrhea? I would ask the panelists as well as the esteemed audience about the differential diagnosis. If you people can comment, please. So, young female, abdominal pain, diarrhea.
This is a painful diarrhea, which is a large volume. So this is locating to a small bowel. So the most common differentials for a painful diarrhea, first of all, it would be infective, like tuberculosis, or second, it can be inflammatory bowel disease in the form of Crohn's. These are the common two differentials which will.
Okay. And anything else we can think of?
Eosinophilic enteritis is very common. You have a uniform involvement of the entire small bowel. It's a, if you see, it's eosinophilic is also one of the possibilities. Then, yeah. Then alpha chain disease, ipsid occurs in younger age group, so that's also there. You can have lymphangectasia causing bowel wall thickening in this age group. That's also one of the possibilities.
She also has proteinuria, so amyloidosis could be a cause.
Amyloidosis in an 18-year-old female, lymphoma, ipsid in a young female, that more can...
Ipsid is known to occur. Alpha chain disease is known to occur in younger population.
Okay.
But basically, you have a complete small bowel thickening. It's not focal thickening. Actually, if you see the CT,
About hereditary angioedema,
Yeah, but there is no history of in the family, sir. No history of any angioedema in the family, and specific GI involvement of angioedema. Exactly.
At times, hypoalbuminemia can also be causing diffuse small bowel.
Her serum albumin was low, definitely, sir. So, abdominal pain with diarrhea, the main differentials initially, chronic abdominal pain with diarrhea, Crohn's disease, drugs involving small bowel such as NSAIDs, lymphoma, vasculitis, ischemia, pancreatitis, and pancreatic insufficiency. So, what do we have? A young female, painful small bowel type of diarrhea, anemia, ascites, mild ascites, proteinuria, and hepatosplenomegaly. So our problem was small bowel disease, hepatosplenomegaly, polycirrhosis, and proteinuria. So can we go a little more in the differential? Exactly, yes. So we did an ANA, the ANA by indirect immunofluorescence, homogeneous, and it was strongly positive. However, the dsDNA was negative. Now, if dsDNA is negative, could it still be lupus? SLE, could it still be? It could still be. SMNT.
ANA very strongly positive, 1 in 320 dilution, and anti-dsDNA is negative. Look at the ANA blood, and if anti-SM is positive in this type of patient, it could still be very specific of
Lupus.
lupus in this situation, if it is.
In fact, it is Sir William Osler. He's the father of modern medicine, the founding professor of John Hopkins. He's the one who had introduced the Osler sign, the Osler triad, the Osler-Weber syndrome. So it is his statement that SLE and GI manifestation, it can mimic any abdominal condition, and any abdominal condition which is chronic, SLE should definitely be in the differential diagnosis. So these are the few studies, the reviews for involvement of SLE, GI manifestation. From the esophagus up to the anus, everything could be involved, including the liver and the pancreas. Esophageal, in the esophagus, it can cause dysmotility. In the stomach, it can cause gastropathy and dyspepsia. Small bowel, vasculitis, enteritis. If we have a biopsy, we call it lupus vasculitis. If without a biopsy, it is enteritis. Celiac disease and SLE, there is an association. 9.7% of SLE patients are having celiac disease. In Europe, where the incidence is 1%, where the prevalence is 1%, SLE is also associated with pancreatitis in the liver. It can cause PSC. Polycirrhosis is there. So we had taken rheumatology opinion, and so I would introduce Dr. Salil Ganu sir, if he can further lead us forward.
Thank you. So, with this background in mind, I revisited the patient. When asked history, she told that she gave a very peculiar history. She had pimples over face, which on elaboration were giving characteristic features of photosensitivity. She said she gets pimples when she goes out in sun, and those pimples remain there for quite some time, even when she comes back to do indoor activities. And on examination, we did find, although fading and faint, some malar rash and some rash over the ear pinna. Now, ear pinna is a typical site of SLE because it is sun exposed. It gets affected very early. So, after further history, we found that she had lost 20 kg weight in last 1.5 months. That is quite substantial, even for simple SLE. So, we had a suspicion of SLE. How do we confirm a diagnosis? Unfortunately, we do not have a gold standard test for diagnosing SLE. As Sir rightly said, ANA immunofluorescence has a very high sensitivity for the SLE. However, the specificity for SLE is low. What that means is we can have other diseases which can mimic GI manifestation of SLE and still be connective tissue diseases, look similar to SLE. Anti-dsDNA, on the other hand, is very specific, but its sensitivity is somewhere in the range of 30 to 50%. That means we might lose 50% patients if we consider negative dsDNA as a ruling out factor in consideration of an SLE. And as Sir said, this homogeneous pattern, what ANA can tell us is this is a homogeneous pattern. This basically tells us that we have some antibody which is directed against a component present inside the nucleus. So that antigen could be anything, right from histones, chromatids, SM. So all of these antigens can produce an antibody which looks like this. We do not test for all antibodies in all patients unless it is specifically required, unless it has some prognostic implication. So what other connective tissue disorders can have presentation somewhat like this, not exactly, but somewhat like this. We can have systemic sclerosis, which can have mesenteric vasculopathy, not vasculitis per se. It is rare in systemic sclerosis, but vasculopathies. So that 20 kg weight loss in 1.5 months is not something that we can explain with systemic sclerosis. And we also did not have specific features of systemic sclerosis on skin. It can cause dysmotility syndromes, so diarrhea can be a part of that. Dermatomyositis can cause mesenteric vasculopathy, particularly juvenile dermatomyositis. By definition, we take it as that happening before the 16th birthday. This lady was 18-year-old, so we can have some presentation similar to that. But even that will have some specific features suggestive of dermatomyositis, which we did not have in this case. Also, this SLIC and ACR classification criteria should not be used to make a diagnosis of SLE, because these are not designed for making a diagnosis of SLE. So this 4 out of 11 should not be used. If we use that, we may miss a lot of patients which are actually SLE and need treatment. So how do we make a diagnosis of SLE? We have to have a correct clinical context. We have to have clinical features which are specific for SLE. We should have immunological evidence of SLE, and we should have labs which support our diagnosis. So in this case, we have a young lady with multi-system involvement, which can be there in SLE. We had specific clinical features suggestive of SLE, that was photosensitivity and acute LE lesions. We sent serum C3 that came out to be low. That indicates that this was an immune complex consumption disease. So that happens in very few of the vasculitis. SLE with secondary vasculitis, RA with vasculitis are the main causes for low complement vasculitis. ANA blot, although we would have liked, but we could not do at that point of time because of financial constraints. We had other supportive lab features like elevated inflammatory markers where ESR was much higher than CRP. That is again a feature in favor of SLE. Renal biopsy we could not do then. So small bowel involvement in SLE can be of lupus enteritis type, which is essentially a small to medium vessel vasculitis caused by immune complex deposits in the blood vessel walls, and it is essentially an inflammatory process which presents with the other clinical manifestations of SLE. Usually it is associated with other clinical features. We can have a chronic mesenteric insufficiency that mostly presents with postprandial abdominal pain and fear of eating. That was not present in this case. There's a bland that can be because of APS vasculopathy and accelerated atherosclerosis. We can have acute mesenteric insufficiency, which usually happens in SLE secondary to thromboembolism from a Libman sac endocarditis in heart or in hypoperfusion states. CT findings are similar in all three, so we cannot differentiate between these three on the basis of CT. Although angiographies, conventional or CT, can make a diagnosis of latter two, we could not do that in this particular case. And antiphospholipid syndrome, for confirmation, we have to have these antibodies. We had an indirect evidence of elevated APTT, that's a feature seen in antiphospholipid syndromes. So what are the CT findings of lupus enteritis? This comes from a small case series, very well done, that had biopsy-proven lupus mesenteric vasculitis. We can get comb-like pattern of mesenteric blood vessels, prominence, peritoneal enhancement, mainly because of ascites, small bowel thickening, and double halo sign. And biopsy is not necessary for diagnosis in a classic case. So we have a diagnosis, SLE with lupus enteritis, lupus nephritis, mucocutaneous involvement, polycirrhositis, and constitutional features. with probable secondary APS and APS vasculopathy. So, what are the evidence for treatment of lupus enteritis? We have to keep in mind that this is a rare complication of an uncommon disease with a very high mortality. So even in future, we are not going to have large randomized controlled trials which give us evidence. Best evidence comes from cohorts. Best available evidence is for steroids. Most of the cohorts agree that at least 1 mg per kg high dose steroid should be given, but most experts think that we should give a pulse. Cyclophosphamide has the next best evidence, and recently rituximab has gathered, there is some evidence with rituximab. So in a case of SLE, we should target the most severe manifestation. So we gave her methylprednisolone pulse, which we later converted to injection dexamethasone because absorption of oral steroids is not that great when a lot of inflammation is present. We also gave her heparin and ecosprin for suspected APS vasculopathy. We gave her cyclophosphamide and the prophylaxis with Septran. So by day 3 of treatment, she had improved. Her pain had subsided completely, loose motions and vomiting stopped. By day 5, we could change her IV medicines to oral medicines, and we had planned for anticoagulation after APLA workup. But unfortunately, after discharge, this patient was lost to follow-up. So what is the take-home message in this case? We have to have a very high index of suspicion, and we also have to rule out other connective tissue diseases. The SLE should be diagnosed based on correct clinical context with SLE-specific clinical and lab features, and ruling out specific feature of other connective tissue diseases. Lupus enteritis, for that, biopsy is not required in classic cases, and it's a rare complication with high mortality. So earlier we start treatment, better is the outcome. Thank you. Yes, sir. So in an ideal scenario, I would have liked to have some evidence of APS. APS by definition has to have a vascular event, which is an acute vascular event with an immunological marker of APS, which is either lupus anticoagulant, presence of anti-cardiolipin antibodies, or anti-beta-2-GP1, either of them. So history-wise, we did not have any evidence of a vascular event, but if her lupus anticoagulant or beta-2-GP1 would have been highly positive, we would have definitely considered that. And we would have started on anticoagulation for a long term.
So only antibodies positive for APLA syndrome, and no evidence of any ischemic lesion.
Yes.
Is it an indication for, or you would like to wait for some ischemic event to occur?
So that is a tricky question, because if we have guidelines are not clear about this particular case, I mean this particular instance, when we cannot biopsy, when we do not have specific evidence or which can be differentiated from, when we cannot differentiate between a vasculitis and vasculopathy causing an event like this, and we cannot have a biopsy, and we have strongly positive antibody profile, probably triple positive antibody profile, all 3 antibodies present, then we are probably justified in starting anticoagulation on a long-term basis. If it is low titer positive, or we have only one antibody positive, that too non-specific, say anti-cardiolipin IgM is positive on only one occasion, probably I would not start that. So, yes.
You have to see 12 weeks apart, they should be rising.
Yes. Again, so that is for classification. That's where we differentiate a classification criteria from a diagnostic criteria. For treating cases, we should not use classification criteria by themselves. These are basically designed to include patient in studies. If our risk of having recurrence of a vascular event is very high, we would probably start her on anticoagulation anyway.
Yes, I think must compliment Dr. Ganu for diagnosing this case. We have involved him in our clinical whenever we have any rheumatology problem. We involve him, and he's one of the best rheumatologists I have come across. So the compliments goes to
Thanks.
Salil for this. And I must tell you that this girl, father was very upset that she had diarrhea and weight loss. I said that we will admit you for 48 hours and give you a diagnosis. And this patient stayed for a period of 10 days. And whatever we thought that what a minor problem, only one symptom that she had weight loss. Otherwise, she would have gone as irritable bowel syndrome. She had such subtle features that it was possible that she, all these diagnoses without workup, would have definitely, because her endocolon and everything was normal. So, you have to have a high index of suspicion in a patient who has weight loss. One has to investigate thoroughly and find out the organic disease. So, in fact, her DNA was positive, so that had given us a clue. And of course, the detailed history of 25 kg of weight loss and all. So, that this was very interesting.
Thank you.
Any comments from the Dr. Arun?
Sir, it was a wonderful case. Kudos to the rheumatologist and sir for telling us about this case. And I want to ask two questions. Was there any biopsy taken from large bowel? And second, what is the long-term follow-up if she comes back? How much is the relapse rate and what the rheumatologist will prescribe, like azathioprine or whatever? Thank you.
So colonic biopsy we did not take. We already made it as a small bowel type of diarrhea, so only the D2 biopsies were taken. About the follow-up, I think sir would better tell us.
So as I said, this is a rarer disease where not much of a treatment experience is available, but this is essentially as a small to medium vessel vasculitis in a SLE, that is secondary vasculitis. So it has to be treated like a similar vasculitis in other organs. So standard protocol for that is giving monthly cyclophosphamide pulse, starting with a high dose steroid, probably pulse, and then at maintaining that 1 milligram per kilogram steroid for at least 1 month, and then slow tapering, that is 10% of dose every 2 weekly. And this pulse, cyclophosphamide pulse, we have to continue for 6 months, and then we have to switch it over to a maintenance therapy, either with azathioprine or mycophenolate mofetil. That will be there for a long time.
Thank you.
Thank you, Dr. Atif and Dr. Salil, for a very nice management of this case. I would like to invite Dr. Yogesh Bang sir for his presentation on surgical management of a surgical problem.
Good evening. My case is a simple one, but reaching up to the diagnosis of what we were facing, it's something which I just want to highlight more. And it's a textbook case which we found. I will show you that also. So this 65-year-old gentleman had a benign gastric outlet obstruction in December 2021. This was his endoscopy report done in Chandrapur before the surgery, December 2021. And for that benign gastric outlet obstruction, he directly underwent a gastrojejunostomy in January 2022. So his symptoms improved for 2 to 3 months. But after that, he started having postprandial bilious vomiting. So the vomiting used to happen 2 to 3 hours after the meals, and it contains mainly bile. There was no food material in that, and there was no abdominal pain associated with it. The same surgeon who did gastrojejunostomy did his 2 or 3 times endoscopy, and every time it was labeled as a edematous gastrojejunostomy site, and he could actually enter the GJ and see the small bowel. That's what also was mentioned. So for 1 year, nearly the patient had underwent 2 or 3 endoscopies with the primary surgeon. And every time this edematous gastrojejunostomy site, he was put on double dose PPI. He was even put on prokinetics, lesuride and all, but there was no relief in the bilious vomiting. And in April 2023, he came to us, same thing, postprandial vomiting, which was bilious 2 to 3 hours after meal. No food material in vomit, no abdominal pain, and there was weight loss as he was vomiting since last 1 year. So after gastrojejunostomy, when a patient has come to us with bilious vomiting, what the report which he had, photos we had was either it was a GJ site issues because of edema or ulcerations. It could be afferent or efferent limb obstruction, but the primary endoscopy was showing photos in which the jejunal loop was seen, or it was something distal small bowel obstruction which was not yet evaluated. So first thing which we did was an endoscopy. I'll show you the video of endoscopy. As soon as our endoscopist, this was because of the vomiting, some esophagitis. As soon as we enter the stomach, there is a large pool of bile which was there in the stomach. This large pool of bile was aspirated, and you can then see some edema over the stomach mucosa, probably related to the biliary gastritis or what. And what our endoscopist was able to do was to see the gastrojejunostomy site properly. It was a very well placed posterior dependent gastrojejunostomy in the antrum there, and then he could enter the jejunal limb. Now he was able to, he could reach up to like 30-40 centimeters of jejunal limb, and he could not find any obstruction in that. And he tried to enter both the limbs, but he was not able to go into the afferent one, and this was probably the efferent one. He was a bit confused because he could see some amount of bile in this, but then why we feel it's efferent? Because of barium which we did later on. So this was the endoscopy picture which the patient had: a large pool of bile, some evidence of biliary reflux, biliary gastritis, and a 30 to 40 centimeter of an jejunal limb which was entered, which showed normal. Next, to rule out any small bowel obstruction, CT scan was done, and in CT you can see the contrast in the stomach which was a bit filled up, and then the contrast which is entering into the jejunal loop completely, and it's going till the mid jejunal loops easily. That's what. There was no evidence of any dilated duodenum. There was no evidence of any dilated afferent limb or a proximal jejunal limb which was going towards the stomach. So after whatever the preliminary investigations we did, GJ sites issues, of course there was some edema, ulcerations were not there. Efferent limb we went in, so afferent limb yet not evaluated completely, but CT was not showing any dilatation of afferent limb, or CT was not showing any dilatation of duodenum. Distal small bowel obstruction was ruled out based on the CT scan. So we got a barium done. Barium was showing a free passage of barium across the gastrojejunostomy site, and within 45 to 90 minutes, the barium has passed up to distal ileal loop. So whether we are dealing with gastroparesis or what, that was the question, and sir asked me to have a look at this patient. And when I was taking the history, this is the textbook paragraph which I have mentioned here, and these afferent loop syndrome, patient fitted in everything which is written in that paragraph exactly, that Sabiston textbook which we refer. So it occurs as a result of partial obstruction of afferent limb. If you look, why the vomiting happens? Because of the forceful reflux of the afferent limb contents into the stomach, and that bile comes out. The diagnosis is usually failure to visualize the afferent limb on upper GI endoscopy, which was there in our case. And one thing which was mentioned is radionuclide studies imaging of the hepatobiliary tree also have some success in diagnosing this. So we went ahead and did a HIDA scan for this patient, and HIDA was showing this, that there is evidence of normal hepatobiliary transit with tracer traces noted in the afferent limb, and showing significant enteroscopy reflux and failure of migration of that tracer into the small bowel loops over a period of 90 minutes. So based on that, we diagnosed this case as a afferent limb obstruction. So the treatment of afferent limb obstruction is very simple. You open up the abdomen, and the jejunum limb which is going towards the stomach and one which is going out, the afferent and efferent have to be joined here. Just a jejunostomy has to be done, so that the bile which was getting obstructed at this point, the bile which comes down through this will enter through this anastomosis and go down. So I don't have a surgical picture of this because we did it within half an hour. We just opened, we could easily see the afferent and efferent limb, and we did the anastomosis, and patient was absolutely asymptomatic after that. So post gastrojejunostomy, there are multiple issues which we can deal with, which we can encounter. These are dumping syndrome, sometimes post vagotomy diarrhea, gastric stasis, bile reflux gastritis, the afferent and efferent loop syndrome, which can be very well treated with endoscopic insertion of double pigtail stent, or either surgically you have to convert it to Roux-en-Y, or brown enterostomy, which we did in this patient. Sometimes you get jejunogastric intussusception. There is sometimes Roux stasis syndrome, in which also again revision surgery is required, or a very rare complication in form of gastrojejunocolic fistula. Just a word about HIDA scan. What we know, we always get HIDA is for cholecystitis, sometimes to look for bile leak, but it is very difficult to localize the area. It can just show there is bile leak or not. And biliary atresia, it's a diagnostic test. What we very rarely use is HIDA scan is very good to detect edge stricture. If you have a patient who has undergone an hepaticojejunostomy and bilirubin is normal, only alkaline phosphatase is rising, there is no symptom, HIDA scan can pick up very early, even before MRCP, a stricture at the hepaticojejunostomy site. Biliary dyskinesia, GB emptying studies are very well done on HIDA scan. And if the patient's gallbladder ejection fraction is very less and patient has biliary colic, the patient will benefit with cholecystectomy. And as I said, afferent limb obstruction after GJ can be very well seen on HIDA scan. Thank you. No, it comes from afferent limb. After there is a lot of pressure which is built up in the jejunum, that goes refluxly into the stomach, and patient directly vomits out majority of that bile. No, through the afferent limb itself, through the jejunum which is connected to the stomach. It is intermittent. It's not an absolute complete obstruction. It's a fluid is going through the, bile goes slowly. The vomiting is basically because of the gush of the bile which enters into the stomach through the afferent limb, that comes out as a vomiting.
You must have examined the GJ.
So GJ was absolutely normal.
But the take-home message is you should always combine it with a JJ.
Yeah, I always, for a benign gastric outlet obstruction or even for malignancy, if we are doing a GJ, I always add a jejunostomy in these patients.
Could you make out whether it was done, I mean, technically speaking, was it done with stapler?
No, I could not make that out.
What might happen when we do enterotomy and we fire the
That's
staplers,
what,
and when we close the enterotomy site, there might be a narrowing if it is closed along the length of the
yes. So post gastrojejunostomy, efferent or afferent limb obstruction, I have seen in my own cases efferent limb twice, and the efferent limb was the end where through which I had inserted the stapler, and the closure had lead to that.
Yeah, that is one thing.
Also, the DJ we practice mostly is it should be retrocolic.
Posterior dependent retrocolic isoperistaltic. Yes. So this was all of those.
Yeah.
The GJ was very ideally done. It was retrocolic, posterior. In fact, as soon as I opened up the abdomen with the same incision, I could see the afferent and efferent limb just below the colon, just exactly at the mesocolon. So it was a very ideal gastrojejunostomy which was done. Unfortunately, patient had this. JJ was not done.
Yeah, actually, this was a diagnostic dilemma because the patient was wandering for the period of 6 months, to the extent that somebody has labeled him as psychogenic vomiting also. He just came to us day before yesterday, and he's gained 6 kg of weight. He's asymptomatic.
Yes.
And absolutely fine. So
we started him on diet immediately on day 2, and there was not even a single episode of vomiting for
when
4
he
to 5
went
days.
home, he was okay, but now also he's
good.
come for the follow.
Yeah.
Good.
Thank you.
I think rather than going for the loop gastrojejunostomy, Roux-en-Y, initially if you do Roux-en-Y gastrostomy.
Sir, for a benign gastric outlet obstruction, making a Roux limb and doing a Roux-en-Y GJ, again a jejunostomy here, I would always do a simple.
But you definitely, if you do the Roux-en-Y, bile going to the stomach, you can definitely prevent, and whatever is the...
Yeah, agree. The chances of having a minimal amount of biliary gastritis can also be prevented with that.
Yes.
Agree to that. There is. Yeah, this Roux-en-Y is without resection. You just fire one staple, you do a hand seven GJ and a jejunostomy here. Right. Thank you.
For small bowel diseases. I would like to invite Dr. Saurabh Mukhivasa for his talk on revolutionary technology for small bowel.
Excuse me. You're on? No. Okay, hi, good evening, everyone. So thank you, the chairpersons, for coming and inviting me. So today I'll be talking about which in my opinion is a revolutionary technology for small bowel examination. And before starting the case, I'll just give you a little bit of a backdrop. And if you think of endoscopy, back in 1807, they made an inspection tube with the help of candle and mirror to look inside the gut. And then, as many of you would know, in 1957, Hershowitz made the first flexible fiber optic endoscope. And then since then, in the 1970s, there's been upper GI and endoscopy and colonoscopy. And then we'll talk a little bit about small bowel evaluation. And starting in 1977, when the Japanese made an enteroscope, and then came push enteroscopy, which was basically an overtube, and the endoscope was then pushed into jejunum to see a little bit of jejunum. Things really started changing in 2000s when you had capsule endoscopy, and for the first time, I think it was quite an eye-opening thing when you could actually take pictures of the entire small bowel, which was still an unexplored territory for most gastroenterologists and endoscopists. So, and then came double balloon and single balloon enteroscopy, and then spiral enteroscopy. We'll talk about that today. So, just for those who are not very familiar with double balloon enteroscopy, and this is an old video of cartoon illustrating the technique. And this is a double balloon enteroscopy, mind you, which is a technique to evaluate deep inside small bowel, for those who are not familiar, where basically it's an endoscope and it has an overtube on top of that, and there are balloons on the endoscope and the overtube. And what happens is you advance the endoscope, which is a longer endoscope than the standard one, and then you use the overtube, which is advanced. Now what you see is with the bowel is pleated on an inflated balloon, and that allows you to go deeper into the small bowel. And this is a cartoon on the left illustrating the same. So for most of you, some of you gastroenterologists have actually performed this. And if you have performed it, you can very well appreciate the challenges with this technique. And the problem is the pan-enteroscopy rate, which is examining the entire small bowel, is limited. It is, when you go in a retrograde manner, it is hard to go across the IC junction, can be challenging, and therefore going in terminal ileal areas is difficult. It's cumbersome because it takes time, and the scope slips and the balloon slips. It takes longer. And then you have limited accessories because your diameter of the endoscope is smaller and the length is longer than your standard endoscopes. And therefore, all the standard accessories don't actually go through this. But nevertheless, this has been largely the bane of our existence for small bowel evaluation. And it has really helped us in many cases. But the advantages, as I said, can be performed as we discussed briefly today. We can do it in pediatric patients, and the outer diameter is smaller. So it can go through most people and adults. And we'll talk about spiral enteroscopy, and a lot of gastroenterologists would be aware of this, and I think a lot of surgery audience would also be aware. But this was back in 2006 when it has its origin. So it's not really technologies which is 6 months or a year old. And basically, it has this plastic tube, which is in a spiral fashion on top. And this was a company in the US which actually created this technology, and they experimented, but it never could reach the commercial use. And until our Olympus folks bought the company and then improvised it. I'll just show you what is the cartoon so that you get an idea of what we are talking about.
In 1950, the type of a gastro camera was
Can you fast
presented
forward
by
this,
Olympus.
So I think let me change
14
this.
years
This duplicate slideshow, right?
later,
So
Olympus
let me just replay this again.
released the
Yeah.
Fiberscope, the Predator
So I won't
marked
go through
spiral
this, but
motorized
basically I'll
the
just
whole procedure, starting with the
highlight
initial
what this is all about. So this is the illustration cartoon as to how this procedure actually is performed.
After
And
passing the ligament of Treitz, the unique design of
this is the spiral tube, which is fitted on top of the special endoscope. And then it spirals its way down into the small bowel and pleats it continuously as it's going down. And you can see how it's pleating the small bowel and smoothly going. And what is very fascinating and interesting, which is for the first time who does this, there's a motor attached. And as all endoscopists, we are used to pushing and pulling, and that's your natural instinct. Here it's motorized. It's like driving a car. You press the button and pedal accelerator, it goes forward. You press the reverse gear, it goes backward. So that's very interesting how it is when you actually start using it. And it's a motorized spiral enteroscopy. So the spiral tube is there and it has a motor attached to it. And so that's sort of the illustration. And if you see, the length of the endoscope is shorter. So your standard colon scope diameter and length. So what it allows is, for those who are doing endoscopy, it allows a lot of accessories to go through. And the working channel is larger, 3.2 millimeters. So a lot of the issues that we face with double balloon are obviated here. The outer diameter with the spiral tube is larger. It's about 3 centimeters. So that's the main challenge of this, because you have to dilate the upper esophageal sphincter with a balloon to facilitate passage. Although these are softer fins, they can cause some mild mucosal abrasions, but largely nothing major. And these are the things. There's this control unit. These are the pedals like a car. You have a reverse and forward gear. So you have pedals, and this is the tube. The safety-wise, it's a fairly safe procedure. All small bowel enteroscopy-related complications, pancreatitis, which happens if you traumatize the papilla, mild stripping, which is common, but adverse event rates is less than 1%. So anyway, so knowing this, and I'll just show you a couple of cases today. The first one is a 58-year-old female with history of rheumatoid arthritis since 8 years. She was on steroids and was taking NSAIDs as needed. She had history of recurrent anemia since 2 years, and she presented with abdominal pain, postprandial associated with distension and non-bilious vomiting. Clinical exam was otherwise non-contributory, and hemoglobin was low, creatinine was normal, albumin was low at 2 as she had chronic rheumatoid arthritis, and ultrasound, upper and lower endoscopy was normal. So post-colon, she had worsening distension, and as we were discussing, patients with strictures can have obstruction, and when you start giving them bowel preps. And this is a CT enterography. You see, this is suggestive of clear obstruction. And there was an area of narrowing, if I could point it out here. Anyways, I'll move forward to the enteroscopy part. And what we are doing is an antegrade spiral enteroscopy, where when I say antegrade, we are going through the mouth. When we say retrograde, we are going across the anus. So here we are doing an antegrade spiral enteroscopy. So now you see the scope is being advanced, and now we are entering the small bowel. Now this video, mind you, is a little increased in speed by my editor. So now we'll go in, and as soon as we get there, yeah, now we are here inside the small bowel. And what we typically do is do it underwater. We don't like to use carbon dioxide as that distends a lot and causes discomfort. This is all underwater movement. And now you'll appreciate how it moves. So this is the motor. I'm basically, you can imagine like how you would see when you're driving a car through a road, and that's how it looks, right? Because you're just pressing the pedal and it's sort of gliding its way through into the small bowel, going very smoothly. And you see the problems that we've always encountered with double balloon are really not what we have to face with this. And soon enough, this, as you can see, within 10 minutes, we reached the site of pathology, and you see there was a tight stricture. It was very short, and we bought biopsies, and then we dilated this using a standard CRE balloon, and then post dilation, this stricture opened up. Okay. All right. Sorry. So the biopsies were obtained and showed chronic inflammation, and from our research team, I don't know if someone's here today. Okay. So from the histopathology evaluation, overall findings were suggestive of chronic sort of inflammation, and the overall feeling was this was drug induced, likely NSAIDs, and it sort of fit the picture with a short circumferential stricture this patient had. This patient was a rheumatoid arthritis patient taking NSAIDs, and this was proven on the biopsy. And the balloon dilation was actually therapeutic for this patient because she came in fact, just yesterday, and she's completely asymptomatic from the GI symptom standpoint. So that's my case number one. And second was a 66-year-old gentleman. History of hypertension, diabetes, hypothyroidism for the last 30 years. He had history of coronary artery disease post-cabbage in 2021. Had a melena, GI bleeding in February 2021. On workup revealed chronic liver disease. Upper GI endoscopy, colonoscopy were normal initially, but then a capsule endoscopy was performed and showed multiple proximal and mid-jejunal angioectasias. So underwent single balloon enteroscopy, underwent APCs, was put on thalidomide, multiple episodes of bleeding and frequency of encephalopathy from the bleeding, was on hemoglobin monitoring with frequent transfusions, about 2 to 4 per month. Hemoglobin was low when the patient presented with low albumin levels. And upper GI endoscopy was very evident. There were a lot of AVMs in the duodenum and the stomach. We initially did the enteroscopy, which I showed you earlier, and we did argon plasma coagulation for whatever I could see, but I could not go very deep in this particular case. So therefore, we did spiral enteroscopy again. And here we see again as the scope's going in the stomach, and now we are going inside duodenum. And what you see now, what you'll start recognizing are these red spots, which are the arteriovenous malformations, the angioectasias. And you can see quite a few of them as we are gliding our way across through the small bowel. You can see all these red spots, almost like a starry sky sort of appearance, and we could go fairly fast in this case as well. This one is a little sped up video. That one was normal speed. This is 1.5 times the speed, but you can see we could go in smoothly down. Now, as you cross the jejunum and you start reaching ileum, the folds become sort of more ovalish, and the lumen becomes larger. And we're going through ileum here, and right. So then something unusual happened, which we are not very familiar with, and we could see a lot of stool, and then immediately we realized that we are actually in the right colon, and we have passed the ileocecal junction, and we reached the right colon. So then we came back and started doing argon plasma coagulation for these arteriovenous malformations. This can be tricky, but this advantage with the spiral scope is it keeps it very stable, which has been a bit of a disadvantage with the balloon enteroscopes. The stability of the scope is fantastic. And then this is, we did, I don't know, about 150 AVMs were ablated. Patient was doing well for 3 weeks, but as you can imagine, they have so many AVMs that these people really require multiple settings. He's requires about 2 times a month blood transfusion as of now. And hopefully, we have requested him to come back for another session, but this is pending. So if you look at overall performance and safety of motorized spiral enteroscopy, this is a recent publication from 2022, almost 1,000 patients. And if you see diagnostic success rate to the tune of 78%, and total enteroscopy rate. Now, this was a unique case where we went inside and we reached the colon, which can happen in about 1 out of 10 patients. And then total enteroscopy rate is about 50%. I would imagine it's a little higher in my opinion sometimes because you can go and mark, and that's not always done in studies. So I would imagine it will be somewhere between 60 to 70%. And therapeutic intervention was successful in 98% per the studies. A lot of them, adverse events were very mild in most of the cases, 17%. So thank you so much. I'll happy to take questions here.
Thank you, Dr. Saurabh, for that wonderful presentation.
Thank
I
you.
would like
Thank
to
you.
ask how safe is spiral enteroscopy in a case where one can have a partial bowel obstruction? As in the first case, after
Yes.
colonoscopy, there were a lot of air in the bowel. So, is it risky? Miss?
Yeah.
Is it recommended to do it?
See, I think by and large, we typically consider this for bleeding issues and thickening when there's no obstruction. We would generally not be doing in bowel obstruction patients. However, having said that, if it's partial and it's subsided and resolved, you could very well go in with the enteroscope and reach there. I mean, people have a habit of preparing the small bowel, but we do give them bowel preps. Yes, we do. But in reality, you don't need to. I mean, you can just give them half the prep sometimes, or even without prep, you're okay. You will still see the small bowel. So the whole idea of giving complete preparation for the small bowel one is not required. You can do half of it. And even if you don't have to, and you want to go ahead and evaluate, it can be done. But of course, if it's huge bowel loops and it's obstructed and you don't want to do it then, because people don't typically do it and I have not tried it. So I don't know what will happen. Yes.
Want to ask, is the right control or it finds its way
Yeah.
totally?
No. You keep putting water, keep pushing the pedal, and then once you encounter the wall, then you have to maneuver it a little bit to get it in right lumen direction. Although, of course, like a usual procedure.
How is the speed? Like you can make a quick turn away from a wall in good time.
No, I think it's the question of.
Otherwise you will.
Yeah. No. It's like you're doing colonoscopy. You see the wall. You don't push it. You wait. And then you find the lumen and then push it. Right. It's the same thing. You're hitting the wall. You don't want to keep jamming it, and it will also measure the resistance. It's safety inbuilt. So when you're reaching that maximum resistance, it doesn't allow it to spiral. So there's safety inbuilt.
But you do take turns, right?
Yeah. You take turns. You use the dials. You get it in the right direction. Let it go. Take turns.
And you keep on irrigating water all the
You
time.
keep on irrigating water without carbon dioxide. Yeah. Yes, we typically start the spiral once we are. No, actually, you start it throughout. You keep spiraling your way from the mouth. So it's throughout. We put water once you're in the duodenum. Oh yes. So I should not mention it is all done under general for antegrade. But if you're going across the anal canal in a retrograde manner, you don't have to use general. It can be done under sedation. Sometimes people have had. We've also done a few cases of retrograde. It is actually not bad, contrary to what people think. Usually what we are used to with enteroscopy is we go antegrade only. Retrograde is not a preferred mode because sometimes, getting that balloon across has been hard. But with this technique, you can go through the colon, you can use the spiral, but once you get inside the ileum, it is fine.
The colon would not get treated.
No, you don't. It doesn't pleat as much. You can do a little bit of pleating. But once you're in the small bowel, in the terminal ileum, the pleating starts then. Before that, it's all, and you're right, but you cannot really reduce it to that extent. But it is not as difficult as double balloon is. Just the context, in comparison. But yes, the antegrade challenge is you have to dilate, and then it can be a little tight. Retrograde, we don't face those challenges. So if something is further down, our threshold to go retrograde is lower than it used to be.
But
Yeah.
as you said, it started in 2007.
Yes.
It's been 16 years, but still not in vogue. Is it because of the diagnostic laparoscopy has an advantage of, say, if there is a band or something,
No.
which
Sorry, I should clarify. The technology was sort of proposed in 2007, but the actual refined final product came like 3 years ago.
okay.
So it only came in the last 3 years. That was experiments, and they were improvising the product. That's what was
As you
going on.
already mentioned, there are very specific indications for doing this
Small bowel,
procedure,
yes,
and
yes.
because wherein the preparation of bowel is possible, like in the
Truly, I
frank
mean,
obstruction, obviously
you wouldn't want to do it because we've not tried it, and it's not proven. But they say there are 20 people who've done it and have been fine. Maybe it is, but we've not tried it because it is not been considered a classic indication. But yes, thickening, partial, resolved, yes, should be done, can be done rather.
and cost might be another factor. I mean.
Cost, yes. So the spiral tube is the one which has limited uses. So that is the cost barrier, apart from the capital cost of the equipment for any hospital. But typical charges are between 60 to 80,000 rupees for one scopes.
I have one question, Dr. Saurabh. With this weapon in our hand now, so should we stop using capsules?
Yeah, it's a very insightful question. And historically, capsule has been the first stay, short of having stricture. If there's stricture, maybe doing this definitely is the preferred approach. But when there's no stricture, we still have been doing capsule, but maybe you can consider going for this, but it's invasive at the end of the day and requires general anesthesia. So I have not moved to complete spiral first approach. I still go for capsule first, non-stricture cases for GI bleeding. And one advantage of capsule is it tells you the, say, bleeding source. Are we looking at the proximal or the distal? And that determines my initial approach for spiral. Would I go anterior or, antegrade or retrograde? So that is the other advantage of capsule. So, and also,
I have two comments. Most of the time, the capsule and the enteroscopy, they are complementary to each other. Sometimes lesions which are picked up by capsule are not picked up by enterography, and vice versa. So around 10 to 15% lesions which are not picked up by the capsule can be picked up by enteroscopy. We had one patient whom we diagnosed recently as a polypoidal mass. So it was looking like a malignancy. So we thought that we'll ask this patient for a surgery directly. But then patient was very young, so we decided to do spiral and do an biopsy. So when we saw with the spiral, it had a stalk pedunculated, so it could be removed. So it was like doing the treatment of it. Patient had so much bleeding that he was afraid that he would not go home. This patient of rheumatoid arthritis, who had a low albumin, was suffering for so long. She had a stricture, and in fact, the enteroscope, spiral enteroscope, and balloon dilatation was a therapeutic to her because we'd done a dilatation. If she would have operated, she would have had, with low albumin of 2.2, she would have problems. Your point of adhesions and it's a separate issue. We are examining the small intestine. The added advantage is knowing the small bowel disease like Crohn's, angioectasias, strictures, getting them dilated. All this we can do.
Yes.
One online question. that can spiral enteroscopy be done in presence of varices in a CLD case?
Yeah, no, good question. No, it should not be and would not be advised. There are certain contraindications, adhesions being one, varices being other. Third would be any of the cases where you are expecting a high risk of perforation, would be sort of the ones. Ulcers, severe inflammation, varices, adhesions. You would not want to do it because obviously the mechanical trauma can lead to problems. So those are, yes, contraindications. I should have mentioned that, yes.
Yeah, so as the mucosa is getting pleated while we move forward in a spiral enteroscopy, if there are some large vascular lesions in small bowel, so can that pleating be harmful? Can that pleating cause bleeding from those vascular lesions? Can it?
Well,
Or theoretically?
if you're talking about the AVMs, no. But of course, with something like duodenal varices, probably. Yeah, that's not what you want to plead. But yes, AVMs you can get away with. Yes. Okay.
Just one technical query.
Yes, sir. Yes.
When you are doing it plicates the bowel.
Yes.
Is it only one end works? I mean, it touches at one part of bowel and pulls it, or the entire circumference works?
Yeah. So you saw in the Illust cartoon, no? So it spirals, and what happens is the small bowel sort of keeps pleating, the entire circumference of it comes. No, so we don't want it very dilated. Now it's 3 centimeters, the total outer diameter with the pins. You don't want it very dilated because it's not going to pleat. So that's why in bowel obstruction, when it's dilated, you will not be able to pleat. And that's the challenge in those cases. That's why we don't put CO2. We only do water, so it's soft, it's not distended, and then it can pleat. If it was CO2, it'll distend, and then pleating can be relatively less. So that's the idea. Okay. Okay. Yeah.
Any comments by Dr. Arun?
I would just like to say an excellent talk by Saurabh sir, and I would like to congratulate Dr. Saurabh. And I would just like to ask, was a CT done for the first patient with rheumatoid arthritis?
Yeah, actually, the CT was done, which we played. I couldn't point towards the suspected strictured area in the jejunum. But
Okay.
yes, there was a short area of thickening in the jejunum, which was picked up. Yeah, that's the reason
So
we did this.
So after dilating, would you do something else, or
No, I
like a
think the dilation
capsule?
was done, and we said let's see what happens, and she's fine. So I think it worked for her. Advised her to stop NSAIDs. So as of now, she's okay. We'll see if things are problematic in future. But the advantage is with all these balloons, we can do a little more aggressive therapy and dilations, depending, of course, on the involvement and how it looks, etc. But those are sort of expanding the role of therapeutics, certainly in some Crohn's patients, because those are patients you don't want to necessarily operate as much. So if you can do a careful, gentle dilation in some of these cases, it can actually be of an advantage for these patients. Yeah.
And sir, how far you can go doing retrograde
I mean,
spiral?
I have not yet reached the duodenum, but you can reach the duodenum from the ins.
Okay.
So yes, that's possible. Yes.
Thank you, sir.
Okay. Thank you.
Moving on to our last talk, which is polyps, and we invite Dr. Akshay Kulkarni to the dais.
Good evening, one and all. Yeah. Yeah. So, good evening. I'll be presenting a very short case of obviously polyposis. Here is a 20-year-old female. She is a college student. There is no significant comorbidities or family history. She came in with diffuse non-specific abdominal pain for 1 month. And she also started having dark stools for the last 2 weeks. There was iron deficiency anemia. There was a long past history of bowel obstruction, and there was jejunal intussusception at that point of time. And this was diagnosed in a private medical college in 2015. She was operated for the same and was managed successfully. Did not have any kind of obstruction since then, was asymptomatic, but now had started having recently abdominal pain. Her investigation showed mild iron deficiency anemia, microcytic hypochromic. Rest of the investigations were unremarkable. Her sonography was normal. The stool routine showed no parasites, and FOBT was twice positive, signaling blood loss. Examination showed pallor and oral mucosal pigmentation. There were no ulcers, no cheilitis, no vitamin deficiencies or Bitot spots, so no nutritional deficiencies. The obvious diagnosis was Peutz-Jeghers syndrome. It is supposed to be a benign diagnosis, and generally these patients are asymptomatic only except for the occasional event of intussusception and obstruction because of large polyps sometimes, and that had once been surgically managed. But now she had presented with us with iron deficiency anemia. There was no menorrhagia, there was no other source of bleed. GI bleed was obvious from the fecal occult blood test. So we were really wondering what to do next. We gave corrections and followed her up, but her HbA remained stable and she kept having dark stools. So there was no response to oral iron therapy, and she started complaining of dyspnea on exertion ultimately. So we had to do something. So we went in, and this is her upper GI endoscopy. So this is the duodenum. There were a few polyps. Unusually large polyps were present near the ampulla. This is one particularly large polyp. So after this, we also did her diagnostic colonoscopy, and we found that there are multiple polyps as well. One particularly large one in the transverse colon, and there were multiple polyps on the lateral duodenal wall as well. So after a lot of pondering as to what to do, we decided to resect the larger of the polyps. It was, of course, obviously impossible to remove all the polyps in her, and they would have just recurred maybe in the next few weeks or next few years. But yeah, we decided to do piecemeal EMR of these polyps, and the larger of the polyps were resected. This was in the blind hope that this would be the source of bleed, and this would lead to at least a partial correction of the anemia and a partial symptomatic relief. So I'll just skip it forward. Yeah. So similar procedure was again repeated in the colon as well, particularly for one large polyp and a few smaller polyps, and we removed quite a large number of polyps in her in the hope that she will now improve. So this was a duodenal polypectomy that I showed in the video, and colonoscopic polypectomy was also done. Larger polyps, which we thought were responsible for the bleed, were removed. There were no complications. A few weeks down the line, there was no recurrence of bleed. She stopped having these dark stools, and the biopsy showed typical hematoma. There was no dysplasia or cancer. She is now doing well, and her HB is stable at 11.2. She does not need any replacement as of now. So with Peutz-Jeghers, this was a serendipitous case for us because generally you don't intervene in a Peutz-Jeghers syndrome unless there is a duodenal or small bowel intussusception and obstruction. And this is usually a surgical indication. You don't relieve it endoscopically. But yeah, some of the papers which have been just case reports, anecdotal reports, not even case series, have reported occurrence of adenocarcinoma of small bowel in patients as early as the age of 7. as you can see in this case report in BMC journal. But yes, other than that, there are currently no surveillance guidelines, especially for Indian patients. Polyposis as such is very uncommon in Indian patients, and all the guidelines actually focus on adenomatous polyposis and other adenomatous polyposis syndromes, where the polyps are actually adenomas, which are precursors of cancers. In Peutz-Jeghers polyps, which are hematomas and absolutely benign, unless you have dysplasia in one of the polyps, you don't generally intervene, and you let the patients be unless they are symptomatic. This was one absolutely off the track case where the patient's where the patient's hemoglobin was dropping, she was bleeding, and we had to intervene. And we selected the larger polyps with a hunch that these were bleeding, and we intervened. We don't know whether this was the intervention that got the success and she stopped bleeding. We tend to we would prefer not to take credit for this one, but yes, she has stopped bleeding now and is doing well. Peutz-Jeghers is mostly benign. Surveillance is currently not indicated. Symptomatic patients should be thoroughly investigated. This is also true despite no surveillance guidelines, and awareness of surgical emergencies like interception and bowel obstruction is essential. And also there is you should always counsel your patients about a small risk of malignancy, because it has been reported. So now that's it. Small case and a brilliant image of a typical adenomatous polyp with the new X1 Olympus scope. Thank you.
Anemia or bleeding is not a common problem
with this patient, where she had some source of bleeding, we ended up thinking that these polyps, especially the larger ones, would be the source of bleeding. Yeah. Not that I know of. I have not seen anemia to be very common in Peutz-Jeghers syndrome, and frank bleed. She presented with melena, so that is also not very common in patients of Peutz-Jeghers.
No, I think this patient actually had sort of little overt bleeding and anemia, and you can look at those polyps and the size. They were pretty ginormous polyps, and the extent of involvement, and you can see starting from duodenal bulb, it was going down to D4, and over time with those polyps, the duodenal diameter was like 2 times the standard diameter. So it was almost like moving your scope in the colon. So you see the polyps slowly, sort of gradually increase the diameter. But I do feel that that was the source of bleeding, because clearly with her large 4 5 centimeter polyp, which Bhushan and I were there, we had removed, I think Bhushan, if you remember, she had a post-polypectomy syndrome with a scottery burn on the colon, because it was a 4 5 centimeter huge one. But yes, these we did in a piecemeal fashion. We showed glimpses, Akshay showed glimpses, but 2-3 settings were required. And, you could not do ESD or something of that sort in these patients, just off note. So we do serial EMRs and serial polypectomy to address it, and it worked quite fine. 2-3 settings, we kept them prepared, and they were totally fine, and she stopped bleeding now.
Such large polyps could be there right throughout the jejunum, and you did not use spirus for this, right?
No, this case was last year. We did not have spiral then.
Okay. So for all you know, there could be more. I mean, you chose to conclude that these are probably responsible for bleeding. You took them off. There may be more bleeding polyps beyond where you could reach.
Yeah, that was absolutely possible, and the patient was counseled regarding the possibility of that, because the polyps are supposed to be present throughout the intestine. Actually, her CT, which I did not show, because we did not select the polyps based on the size, the accessibility, and the largest ones that we could access were resected. We did not go into the jejunum, but we did tell her that this might be the source of bleed, and she can bleed again. But she never had any emergency in the form of a huge bleeding or a major bleeding, did not require regular transfusions. So we counseled that even if she does bleed again, maybe iron replacement might work, and we might have a backup plan later with.
No, I mean, we can
with
always do
endoscopy.
the capsule
Yeah.
to identify the number and location with the access. We could always do it, but currently, since clinically not indicated, we have not ventured into capsule right
Yes.
now. But why not? It's worthwhile.
So,
You should do it now. All the polyps are out, so that can be done. Which this is all in the D1, D2, D3, D4. So it's standard endoscope.
I doubt if spiral will be safe in this patient, because multiple polyps again. Yeah, it can take.
I mean, if you can remove it
really damage.
sequentially, it can be done.
Huh.
It's not that bad.
Akshay, all these Putjagger, they have more chances of malignancy in the small bowel.
Yes.
There are large colonic polyps, but they have more chances of small bowel malignancy.
Yes. So there have been at least 10 case reports all over the world in published literature about small intestinal adenocarcinoma. It's a well differentiated adenocarcinoma, and the pattern is consistent. It's a type 2A small intestinal well differentiated adenocarcinoma that develops with Putjagger's. It's always small intestinal. You never get colonic malignancies with this, but only 10 case reports you never know.
And is there any follow-up of these cases? Say, for example, if you removed the polyp, because of the genetic mutation which makes you more prone for polyps, how much will be the time required for development of next lot of polyp? Any studies?
No. Actually, there are about 148 studies from India and Asia Pacific region itself, which is supposed to be a population which is supposed to be not so prone for polyps, and especially hamartomatous polyps as well, because there are very few studies and very few case series about polyposis from this region. But still, there are some reports of adenocarcinoma developing, but there is not even a single report, or not even, as far as I'm aware, the chairpersons and other enlightened audiences can correct me, but I am not aware of any publication reporting resection of such polyps, because it is supposed to be benign. So there was no resection and follow-up literature.
So
it's justified to remove the polyp if they are causing bleeding, intersusception, obstruction.
So larger polyps, if they are causing intersusception, then removal can also be an option. But generally, because these larger polyps, they are present in the intestine, and they most common site of intersusception is either duodenum or jejunum, where the patient presents with an acute emergency and then has to go for surgery, because that intersusception is so large that it can also telescope the entire half of it of bowel and can cause bowel necrosis. So generally endoscopic treatment would take a backseat.
No, you're right. I think we need to understand, when we say polyps, we think of cancer. So not all polyps turn into cancer. Putjagger's exceedingly rare, as Akshay correctly pointed out, that they turn into cancer. So you need to have a good reason to do any degree of removal, because for whatever, you're doing something, there's a risk of bleeding, perforation, etc. So it can only be sort of justified, I would imagine, in the cases which are symptomatic. Bleeding, obstruction, etc. Now, 10 case reports of adenocarcinoma and you want to remove all the small bowel polyps may not be justified. That's the feeling. But if it's symptomatic, and as the case is with most things in GI and whatever medicine, if it's symptomatic, you should be considering addressing those issues.
Two small questions. The malignant change occurs within the polyp or away from the polyp? Number two, and is there a reduced life expectancy of these patients?
So the adenocarcinoma is well differentiated. All the case reports that have been there, the youngest age that the patient has presented, again, he was a known case. He was a 7-year-old kid presented with small intestinal adenocarcinoma, was known case of Putjagger's, because his young elder brother was also a case of Putjagger's. So the family was screened. The younger boy also was found to have Putjagger's. Later, he got symptomatic with obstruction, and when the ileal intersusception was resected, that time they found out adenocarcinoma. So that's the youngest case I'm talking about. The other 9 cases, again, they have become symptomatic with obstruction, and only then
the question is whether the malignant change occurs within that hematomatous polyp or away. That's my question.
So that's
Is it
really
known or
not. No, that's really not
because
focused
then
upon. The,
there's no point in removing because some certain conditions in the stomach, benign polyps, they are prone to malignant change away from the polyps.
Yeah. So the exact site of development, because hamartoma itself is a benign polyp, so that's very insightful. The adenocarcinoma might even be developing away from the polyp, but all these patients have presented with obstruction or other symptoms, and then they found the larger lesion to be adenocarcinoma. So whether it developed in a polyp was a very moot question. No. This can, yeah. One would logically think so. Yes, this can occur away from the polyp, but there is no evidence for that. Autosomal dominant. Dominant. Fluid. Life expectancy, if you are asymptomatic and you don't face obstruction, is supposed to be normal. Purgers have been known to survive just as at par with normal people.
These textbook cases, Dr. Akshay. Thank you so much. So I would say that this is the conclusion of all the clinical cases discussion. Thank you.
Thank you very much.
Yeah, it's a nice 111 Midas meet we concluded. We really thanks our chairperson, Dr. Atul Gawande sir, Dr. Shashank Vanzari sir, Dr. Gaurav Padia, Dr. Prakash Jain sir, and also the online chairperson, if it is Dr. Hitesh Dude, Dr. Arun Iyer sir, Dr. Vikas Singla sir, I think they are not available. And we are really nicely concluded this meet, and I really welcome for cocktails and dinners from us. Yes, just join us.